Well, it's 12 o'clock, so I'll start. We probably have some people who will jump on in the next couple of minutes. They're not here to see me, they're here to see you. So um, I'm Julia Haggerty. I'm the interim director at MSU for the Montana Institute on Ecosystems, and I want to welcome everyone to our Rough Cut seminar today on Wednesday, October 6th. And this is a seminar that's part of an ongoing series focused on climate science, climate initiatives, climate practice at the IOE this fall. As part of that series, next week, we'll hear from Dr. Paul Belmont and Dr. Paul LaChapelle from Utah State and Montana State, respectively, talking about the role of land grants in addressing the climate crisis. So I hope you can join us for that. Today, I'm very pleased to welcome a visitor from Missoula, Dr. Elizabeth Schenk, or Beth Schenk, who's the Executive Director of Environmental Stewardship with Providence Healthcare. And as you know from her bio, she has an impressive record of leading environmental education, stewardship initiatives in the healthcare system. She's also an assistant research professor at the Washington State University College of Nursing, and she has developed a number of professional and research-focused tools across the healthcare industry. So Beth, thanks so much for being here. We've got people joining in, and this meeting is being recorded. If you have any bandwidth issues, you're welcome to turn your video camera off and then turn your camera and microphone back on when we gather for questions and answers at the end of Beth's prepared remarks. So thanks so much and welcome, Beth.
Thank you so much, Julia. It's nice to be here and nice to learn more about what you're offering. As Julia said, I'm Beth Schenk. I live in Missoula. I'm a long-term Montanan, but most of my work is really west of Montana, as I'm leading the environmental stewardship work in Providence. And Providence is a large health system on the West Coast primarily, and I'll be telling you more about that. So what I plan to cover today is a bit about the challenge of environmental stewardship in healthcare, the impact that healthcare has, and then give basically a case study for Providence in terms of what we're doing, including the boldest climate goal in U.S. healthcare today, which is to become carbon negative by 2030. It's enormously challenging. It's really interesting. So I look forward to telling you about that. But first, I'm going to give some background into what's the big deal about healthcare and environmental stewardship. So I'm going to turn off my video because of the bandwidth issues, and I'm going to try and finish my remarks by quarter till. So, and in the meantime, I'll try not to talk too fast, which I tend to do. So first, healthcare is really significantly polluting. In fact, 8.5% of U.S. greenhouse gas emissions come from healthcare. Globally, global healthcare is about 4% of greenhouse gas emissions. And if you stack that up, it would be the 13th, if it were a country, it would be the 13th highest emitting country in the world. And of the global healthcare emissions, about 27% of those are from the US. So we are outsized, as we are with other aspects of greenhouse gas emissions, in our healthcare emissions. So you might say, well, where do they come from? This is a very simplified image of some of the sources. Supplies and materials, and I will tell you on a slide later that almost 40% of our greenhouse gas footprint is through supplies and materials. Waste, fleet vehicles, all the HVAC stuff, which is what we typically think of, but actually in our case, it's only about 20%. All of our energy use is about 20%. Waste anesthetic gases, I'll tell you more about that, plus nitrous oxide. Food and meat, employee commuting, and there are others that all align with the International Greenhouse Gas Protocol, which is what we're using to tabulate in Providence. Other elements of environmental pollution in healthcare: second highest user of energy in the commercial sector, and hospitals themselves are generally 2 to 3 times as energy intensive as office buildings. And we know now that transportation is outpacing buildings in terms of sources of greenhouse gases, so that's a big piece of our footprint in healthcare. Complex waste streams. So we think there are about, the way we tabulate, 12 or 13 different waste streams. Some are highly regulated in terms of hazardous waste, narcotics waste, biohazard waste, pathological chemo waste, et cetera. And we create an enormous amount. 7,000 tons per day is a hard number to wrap your head around. Another way to think about it, and this is the 29 pounds per patient per day. The average household is around 4.5. So And that's a low figure because that's taken from one of the only databases that exists, and that is of hospitals and health systems that are working on this. So those that are not are probably up around 40 to 45 pounds per patient per day. And then chemicals is another category of concern. From different studies, body burden studies that have been done, we know that nurses are second most exposed profession, first being janitorial staff. And this is to occupational chemicals in healthcare. Physicians and other providers are also exposed, pharmacists, if they're not taking care with the medications they handle. Also, chemicals are a source of greenhouse gases, which I'll tell you more about. And this impacts all of us, including patients in the hospital, staff, and our communities. So this is what I call the healthcare and environment circle. People come to us for treatment of their disease and illness. They access healthcare services, which then causes healthcare pollution, which then contributes to disease and illness. We are trying to break the cycle right here at this inflection point to decrease healthcare pollution. We know that right now, healthcare is not held accountable for its pollution. It's not regularly measured or reported. It's considered voluntary to do so. Our funding is not impacted by this. Costs are, and I'll demonstrate, I hope, that to do this work saves costs significantly. But it's off of the radar of many managers, directors, and CEOs. However, healthcare pollution, we know from a study in 2016, creates harm on the same order of magnitude as other healthcare acquired conditions like infection, falls, skin breakdown, medication error, etc. So if we're causing the same kind of harm through our pollution, that means it's something we need to do something about. And we do focus on other aspects of harm. We've focused very seriously. HRO is a high reliability organization. That's a methodology for driving out error. We focus, immensely on our quality outcomes. Our rankings matter from this. Our reimbursement rates matter from this. So we certainly pay attention to quality, but for some reason we're blind still today to the quality impacts of our pollution. So we think about this in healthcare, but of course it's part of a bigger picture. And this really is my obsession, my passion, and I imagine what many of you on this call are concerned about. So we see the degradation that we're causing the planet. We see the health impacts it's causing. And as a healthcare professional, this is offensive, especially that we're driving towards this in healthcare. So these problems are worsening, from climate change to biodiversity loss to the introduction of novel chemicals. And these are all some of the roots, of course, of our planetary crisis. I just suggest this definition as a framework. Planetary health, put simply, it is the health of human civilization and the state of the natural systems on which it depends. So when we're thinking about health, we cannot divorce ourselves from the health of the state of natural systems. We're dependent on that. We're interactive with that. We are it. So that's why this is a driving concern in healthcare. When I look at the long list and consider all the aspects of planetary health that may come into play, I have identified 3 as being particularly relevant to healthcare, partly because these issues lead to health risks and also because healthcare is making them worse. And those are climate change, of course, biodiversity loss, partly through the chemicals that we use, and resource depletion, partly through our extremely wasteful habits. So I tend to focus on these in my when I'm trying to link care at the bedside to planetary health, which you imagine is quite a gap for clinicians who are very keyed into metabolic processes and the ability for people to make behavior changes, to think about, well, what does this have to do with the planet? But it certainly does, and we need to more and more make those connections. So I find the planetary health framework helpful. You all have seen this slide. It's 10 years old from the CDC. I only mention it as a reminder of the health impacts that come from climate change, which then are directly, we should answer to them in healthcare. We should also be aware of them as we're seeing more patients and families and communities worsen in their conditions related to this. But I'm not going to go over this in detail, but please, if you haven't studied this, take a look. It's still, I think, very relevant after 10 years. And unfortunately, these impacts do not impact us equitably. Communities of color, older adults, low-income communities, children, people living with poverty or homelessness are all more vulnerable to the health risks associated with climate change. So this, again, violates our sense of justice and fairness. which is one of the reasons that in my work at Providence, we're really focusing on environmental justice. And I'll tell you a little bit more about that. But compared to that other picture I showed you, this is a different future that we can also still achieve. It does not have to be that way with our heartbreaking results from the different aspects of climate change and pollution. We live on a planet that's regenerative, that is healing itself. We have the capacity to take care of it, but of course we have to change the way we do that to do so. So that is a question that I live with all the time. And we are at this critical point in time. We're told by the scientists that this decade is of critical importance. Right now, it has mattered for the past 4 or 5 decades, beyond that, but it matters a lot right now because we're running out of time. So I think this is just an important question, of course, that you all are asking yourselves, and that we need to do more so in healthcare. So that's really a lot of the impetus behind my work. This is certainly what, as I say, keeps me up at night. I'm deeply curious about what will happen. I think we'll know a lot more by the end of the decade. I hope that we'll know more by mid-decade, particularly. I hope we'll know a little bit more by the end of COP next month. So I'm going to introduce you to a framework that I've developed, partly because in it, I house some of the issues that arise in healthcare. And it's called the We Act Please framework. So first of all, what is environmental stewardship in healthcare? It's what you would think it is in terms of the use of responsible practices, products, and processes so that we can live in a way that is in balance with nature. I used to use the term sustainability a lot. I have backed off of that, honestly, partly because it's confusing. People use sustainability for all sorts of reasons, financial sustainability, workforce sustainability, but also because we are so far from being sustainable. I think it's misleading to say that, yeah, I work on, I'm getting us to be sustainable. I don't think that's realistic right now. And yet we do have to continue to chip away and get as close as we can, for the next several hundred years, I'm sure. Why should healthcare care? I've talked about this a little bit, but to make a few more points, generally when we save resources, we save money. And so working on efficiency is a way to drive down our resource use. And to measure that and to report on it, meet organizational commitments, attract and retain employees, demonstrate leadership, meet professional obligations, etc. So you might think about where would we begin? And environmental stewardship in healthcare is really quite complex. Corporate sustainability has its own area of the law. Carbon accounting is complex and confusing. Daily operations in a hospital or home are challenging to do sustainably or even efficiently. So where do we begin? So really all of these issues that come together to create and inform an environmental stewardship program kind of turn people off. They overwhelm people. It's kind of like, where do we begin with climate change? And we all know on this call that there are definitely ways to begin and there are ways to work on it in depth. But sometimes even thinking of all these things at once makes people crazy. So I developed the We Act framework for that, chunking this into 5 categories, the first being waste. So I mentioned that waste is very complex in healthcare, and it certainly is. You can see on the left a list of common waste streams, and there are substreams for each of these. Many of them are very expensive and highly regulated. So what I've got on the right is opportunities for action. And so certainly segregation into the right waste stream is an important place to start because overtreatment of waste is a problem. Source reduction, this is really the holy grail. It's to stop bringing the stuff in the first place. And there's lots of ways to think about this, and yet it's very uncommon for the most part. We continue to be a disposable culture in healthcare. And we want to get more toward reusable and reprocessed items and also better use and selection in the first place. And to just use less through practice change. So what about the climate impacts of waste? Well, as you know, waste in landfills creates methane, and depending on the type of waste, but we want to drive stuff away from landfills and away from incineration and autoclaving, which are the heavier treatment modalities. Also, the overproduction, shipping, use of goods contributes to greenhouse gases. So this gets us back to source reduction. We want to use less to begin with. And also that's an opportunity for remarkable savings, millions and millions of dollars of savings just in our health system alone. And then also over the utilization of resources as we strip the natural settings around the world, that reduces the resiliency of those ecosystems. Oops. So the next one is energy and water. So this is often what people think of when they think about climate. As I mentioned, this is important, but not the only piece of what we're looking at. We are certainly trying to get off fossil fuels as quickly as possible, as is the world, and we need the world to act for us to be able to as well in healthcare. Water is sometimes an underappreciated issue. We're seeing it certainly right now with as climate exacerbates, as our drought in the West exacerbates, and as our fires continue to grow, especially in California, Oregon, and Washington, where most of our sites are. So what can people in healthcare do? Push for renewable energy sources. Now, we have an entire plan for how to do that, and I'll talk a little bit more about it. But this is both through on-site, which honestly is, in my opinion, going to be a small piece of the puzzle in healthcare. For instance, one of our hospitals in Centralia, Washington, has the largest solar array on any hospital in Washington state history. It's very large, and it provides about 10% of the electricity needs. It's just not going to be feasible for us to depend on site. So we're pushing hard on our governments through advocacy. And luckily in some of our states, not Montana, we have excellent renewable portfolio standards. Washington is slated to be 100% renewable electricity by 2030, California by 35. We're also working hard to achieve power purchase agreements, green tariff arrangements, virtual power purchase agreements, et cetera, as we try and get toward 100% renewable electricity by 2030. Efficiency and conservation, of course, and water conservation. So in terms of climate, you already know these things about fossil fuels being the biggest driver. Coal is most polluting, but we are still using it. And also the treatment and distribution of water is energy intensive. We may not think about that as a climate impact, but it is. The next category is agriculture and food. And this is important for a variety of reasons, not first of which it's material to consider. Second of all, it's a real important engagement topic for caregivers and the public, because we eat regularly. We like our food, we care about it, we know about it. So we have a lot of challenges with our agriculture and food system, including food waste. You can see some of the figures here, including probably still an overdependence on meats, and that includes not only greenhouse gases, but also antibiotics, growth hormones, the difficulties of the concentrated feeding operations, and waste. Produce, also some issues related to growth, chemicals, environmental justice issues, and transportation and distribution, and packaging. So what are some of the things that we can do in healthcare? Certainly we can support local and sustainable foods in our purchasing, and there's a lot happening on this front, actually. Those both support local economies and help build self-sustaining communities. Hospitals can offer CSAs and gardens, and those are two pictures on the right of CSAs and gardens. Reusable dishware, really kind of staying away from the plastics, and even compostable unless you're very sure that it's going to be composted. More organic foods and less hormones, healthier beverages, etc. So climate impacts of agriculture and food, this is probably already clear. The estimates of how much animal agriculture contributes varies a bit, but it's significant, 14 to 18% of greenhouse gases globally, and those are some of the higher offenders there. Food waste is an important contributor. And then land use. This is an important concept, again, from the planetary health perspective about resource depletion. As forests get mowed down around the world to help grow food for our economy and others, that can create problems. The C is for chemicals. So chemicals have been a concern in healthcare for a long time, largely through staff exposures, exposures to patients, and in waste. This list on the left is a common list of chemicals of concern in healthcare. These are ones that we watch, we try and not purchase. It's very difficult to keep them out of everything. But I'd say this overall, we in healthcare have made progress over the last few decades. Not solved, don't get me wrong, but there's a lot more awareness. I was very pleased to read that California, I just read it this morning, California has adopted to move away from forever chemicals, PSA, and et cetera, PFAS. That's terrific because California often leads the way. So What can we do about this? First of all, I always tell clinicians, especially, to protect themselves, because when there's not awareness, then there's not protection. And so we need to learn about the risk and use the precaution that we need to. Also, to reduce and eliminate. What opportunities do we have for substitution? How can we begin to track how much we're talking about in terms of chemicals, how many dollars? We have to work with our vendors and the manufacturers to both get at transparency and also to reduce. And then we can request justification. Do we need this chemical? And this can range from pharmaceuticals to cleaning chemicals to chemicals in foods, chemicals for integrated pest management, chemicals for our lawns and yards, etc. So now, climate impacts of chemicals. In healthcare, one of the bigger areas in terms of chemicals has to do with our anesthetic agents. So I was telling you a little bit about this. Waste anesthesia gas that is just vented straight outside. It's not vented into the OR. So this is, the waste, the gas goes into the body and it is primarily exhaled in the same form. It does its job, but it's exhaled essentially in the same form and amount. That then has to be vented outside. So it is vented straight into the atmosphere, and some of the chemicals are up to 3,600 times as potent as CO2. So this is very potent. They tend to be expensive as well. So this is a project that we've been working on to really reduce those. Nitrous oxide, similarly, it's 298 for its global warming potential. A lot of wastage, a lack of knowledge about this across the nation. We've been really working on this. Others are, as you know about, petrochemicals, et cetera, being the highest emitters. And those are in everything not everything. Those are in much of the products that we use in healthcare in terms of our plastics and building materials. So it's important to think about chemicals, both from the toxicology side, both also from the greenhouse gas side. The last of the categories is transportation. As mentioned, transportation has passed buildings as the largest source of greenhouse gases since 2018. And we are looking at transportation in a variety of ways, from employee commuting to our business travel to distribution of goods, et cetera. This one's a hard one because everybody has to make their own choices and get to work in different the ways that they need to, at least in terms of commuting. Again, we benefit from the states that we're in. Washington State has set the goal to not allow new sales of gas-powered vehicles after 2030, and California, 2035. So that will help tremendously. So what can people do? Well, the same things that we've been trying to do for 30 years. Encourage public transit, reduce personal dependency on single occupancy vehicles, move toward electrification of the sector. So I think the climate impacts are clear. So that makes the We Act part of the framework. And I hope you can see that by spelling very simply 2 words, We Act, that gives us really what we think is probably about 90 to 95% of our emissions, not just ours, but really the globe's emissions, because these basically are the categories, if you think of big categories, that they would fall into. Also, by saying We Act, it reminds people that this is not something that's going to be solved by someone else somewhere. It really is going to take all of us. It is taking all of us, and it takes action. Okay, so I'm briefly going to just talk about the please half of this, and then I'll get more to Providence. This is really a leadership framework, but the reason I think this is important is because people, especially, maybe it's just healthcare, I'm not sure, they just don't know how to get started. They don't know really how to make this happen. So I've identified a few elements that I think are just pretty darn important. First is professional obligation. And you've heard it all the time, do no harm. And there's a complicated story behind that phrase, but in a nutshell, all of healthcare probably would adhere to that. We don't want to do harm. We're here to help. If in fact we're actually driving up carbon emissions that's causing immense harm, then we're violating our own principles. Some disciplines, including my own, have more specific admonitions, and this is one of our standards of practice in nursing. The registered nurse practices in an environmentally safe and healthy manner. This is a standard of practice, just like we respect the dignity of the individual. We also aren't supposed to pollute. So I think professional obligation in healthcare can be a significant anchor for the work we do. Leadership is important everywhere, both formal and informal. The formal leaders can really find the resources, do the planning, help with decision making to make it possible to try and change and transform healthcare. And then we always need influencers and thought leaders behind the scenes or in front of the scenes who are pushing and asking and demonstrating leadership through their own actions and role modeling. The first E is for education, and you all are quite familiar with education. Not surprisingly, environmental stewardship and even climate change information is frequently lacking still in the clinical professions. It's just crazy to imagine. I've been working on that for 15 years and it's still the case, but making progress. And then there's practice-based education. So for instance, for anesthesiologists to understand those implications of their anesthetic agent selection, it's an important piece. Excuse me. Okay. And then ongoing education as well, of course, and lifelong learning. The A is for accountability. So this is really important in terms, I think this is where metrics falls. Metrics are key. This is very data-driven work. It both for the utilization of the entity, whatever it is you're measuring, the cost of that and the savings, we hope, and also the carbon emissions and any other aspects of environmental stewardship. So this is really hard to do in a complex environment like healthcare, but very important. And we can weave this all into other measures, including operational performance evaluation. So that really gets quickly to accountability amongst people. The S is for science. We would assume this doesn't even need to be said, but it certainly does today. So this is an opportunity to remind clinicians particularly that they are science-based and they are scientists. And so it is not only important, but necessary that they follow high quality, peer-reviewed science. And there's an enormous amount of that for climate change, as we know. And so it's important to stay current and to teach others about that. When not fully clear, we encourage the use of the precautionary principle. Use the best evidence we have. Don't just ignore it, waiting for perfection. And also to contribute to the body of knowledge through our own research and sharing those findings. The last E is for engagement, which I think is the secret sauce. It's really getting people on board, talking with them, inviting them, encouraging them. This is an opportunity for retention in healthcare, which you know right now is really tough. There's a lot of folks leaving the field because this is working toward one of our biggest challenges ever. And it can help them work with meaning and purpose in their own lives. We also want to use our powerful health voice in advocacy. It's very important, and clinicians do this less often than you might think. And there's been a number of studies that can defend that statement. So that tells us, that is then the please. So we have the We Act Please framework. And I hope and have been told that We Act particularly really kind of helps people think about this in more concrete ways and also gives them some guidance. Okay, so I'm going to now just talk a little bit about what's happening in Providence as a case study. And then I would love to hear from you about any questions or input you have, especially about healthcare or health. So first of all, Providence is a large health system, 51 hospitals, over 1,000 clinics, 120,000 caregivers. That means employees for us. And in these 7 states. So we range from Alaska to Texas. And as mentioned, Washington, Oregon, and California particularly are quite progressive in terms of climate action and regulation. And that helps us because that is where the largest number of our hospitals are. In Montana, we have 2 hospitals in the western part of the state, in Missoula, where I live, St. Patrick, and in Polson, St. Joseph, and probably 40 to 50 clinics. We also have the University of Providence in Great Falls. And just as a fact of curiosity, St. Patrick, out of all these hospitals in all these states, is the oldest Providence hospital. It was formed in 1873. So there were Providence hospitals formed before that, but those have gone away or been sold off. But St. Patrick has been on the same property since 1873. So people have pilgrimages to Montana about Providence. So we set the goal and we announced this goal. Our CEO, Dr. Rod Hochman, announced the goal on Earth Day of 2020. So that was the 50th anniversary of Earth Day. I remind you that that was right in the middle of a pandemic. It was in the early days, we now know, of the pandemic. The first case of COVID in the United States at a hospital was at one of our hospitals in Everett, Washington. It's a suburb of Seattle. And so But nonetheless, there had been more and more angst about our situation with our environmental crisis. And a lot of work had been done over the past 20 years in the health system. So we declared that our goal is to become carbon negative by 2030. So it makes sense. You're all familiar with what carbon neutral means, and carbon negative just means taking even more out of the atmosphere, primarily through offsets in our case, since we're not in the business of sequestration ourselves. So that is our goal. And in the process, we will meet some of these targets listed on the bottom of the slide. Environmentally respectful operations, building resilience and justice, engaging caregivers. And we know that to be healthy, we need a healthy environment. We need a healthy planet. And that's really circles back to that concept of planetary health. Well, what do we mean by carbon negative again? We are considering all three scopes. So you all are familiar with the greenhouse gas protocol. Scope 1 are those emissions burned, combusted on site. Scope 2 are indirect, but it is from purchased electricity and steam. And Scope 3 is really everything else from all of our indirect work. So just a little bit more on that. If we look at our footprint so far, and this is a high level, a lot of this actually is estimated because it's quite hard to measure, especially in the supply chain. But what we find is it's about 20% that is in our energy. This is what I was saying before. And the bulk is in our supply chain, travel, waste, and investments. So we are working on the whole foot here, and it's very, very challenging, but also fascinating. We've set one more goal, and that is our waste goal, and that is by 2030, we want to send less than 50% of our total waste to landfill or incineration. After working on this for a long time, 2 decades, I think this is a reasonable metric, and I would need to take you through all of waste in healthcare to convince you probably of that. But what this drives us to primarily is source reduction, which I think is the real way we handle both waste and overconsumption. But to do so, we have to increase recycling and composting, which are lower intensity disposal methods, and also they provide some good for the future. To segregate properly, as I mentioned, and to increase donations for things that are still high quality that we can't use anymore. Source reduction being the key here. So we use the WEACT framework in Providence. So I just told you about that. And this is a very high level version of the WEACT Please framework, what you see on this card. But this gives you some ideas of some of the topics we're working on. And I have this in more detail. So for instance, in 21 and 22, we are working on what we call waste optimization, of getting the right waste to the right stream at the right cost across all of our sites, which is enormous process. So we have started by doing an assessment. We're developing a playbook right now, or a best practice guide for all of us that'll be finished at the end of this year. Then in 2022, we will instill that through an action plan at each site. And then by 2025, so long-term thinking, we plan that each site will have all the pieces in place. And then by 2030, they can get to that optimized state of sending less than 50% to landfill. Energy and water, we're doing a lot. I mentioned a little bit of this already, and I won't go into great detail here, but a whole lot of energy audits, deep energy retrofits, working on renewable electricity sources, water conservation plan across all of our sites. Our problem and challenge is with natural gas, as it is with many sites. We have some old buildings built in the 60s, 70s, and we're not going to be able to replace all the power plants in the next 9 years now. So we're going to have to be offsetting some of our natural gas use. We know that. Agriculture and food, I have told you a bit about that. So we are working hard to reach about 30% of our food purchasing to be sustainable, and those are nationally agreed upon definitions. We're working on getting composting in every site. We're joining Healthcare Without Harm to decrease our carbon intensity of foods by being more plant forward and measuring that and reporting that to a national database. So working on various ways on food. Chemicals, I've told you about that. Right now with our anesthetic use, we've already decreased greenhouse gases by 69% and saved millions of dollars. And we're now working hard on nitrous oxide. We've only gotten to about 20% so far. It's a little bit squirrely, and yet that's what we'll be focusing on in 2022. Transportation, we track our business travel, our commuter emissions and our transportation through our supply chain as well. I told you how important data tracking is. So we've developed the WEAC scorecard. This is a fabulous Power BI tool that tells us so much. It's just incredibly valuable. We benefit from having a team of Providence caregivers. They're Providence employees, but they're located in Hyderabad, India. It's called the Providence Global Center. And I meet with them several times a week to help drive this work forward. And it is really fun. It's really fun to learn how databases and scorecards are built, and how you pull in an API from different data streams to get it here, how we validate it, etc. So this is super important and very technical, but really fun. I mentioned to you that we're using the greenhouse gas protocol, and I just used this slide to show how what we're doing in WEACT is related to the protocol. And I have a few things circled there, and this is mostly when I talk to caregivers or employees. Waste and employee commuting, and I would also add electronic use and food are something that impacts everybody every day. Most people don't really think about the water probably, or even where their energy is coming from, but we interact with these categories every single day. So I consider them to be kind of powerhouse categories because of the engagement potential. So far, after about a year of work, we've reduced our emissions by 6%. This we think is good. And of course, we have a long ways to go. This is just an idea. This is not terribly scientific, but it's helpful to explain to people within Providence of where we are so far. How are we doing? And what percentage of the way are we there? So we'll update this about annually, and it gives people ideas and a little bit of information about what we're doing. So for instance, you can see on the far right, we've dropped our flights by 90%. Now that is because of the pandemic, but I'm super proud of our leadership who has said we want to keep our business travel at 25% of our 2019 levels. That's astonishing. My own recommendation was 50%. I'm thrilled that they want to go lower, but it makes so much sense. We have our virtual meeting tools. People get tired of travel. So we do have several pieces in place for leadership. This is a diagram of our formal leadership team called the Environmental Stewardship Transformation Circle. These are all divisions within Providence across this entire system. And we have leaders who help drive this work. This group is really accountable for meeting our goal. And then we're divided into 7 regions. And so we have regional representation as well. And that's how we reach out to the hospitals and clinics in the different regions. There's a few other organizations or divisions that tuck up under this. And one is what we call ACEs. This is an Action Collaborative for Environmental Stewardship. This is an open meeting for any caregiver in Providence. And we've been meeting since 2008. So that's just an idea about how long some of this work has been going on. And that's important for historical knowledge, institutional knowledge, and it's kind of reassuring to people, I think. We have a technical advisory committee. That's a smaller group that really dives into the details on carbon accounting and on best practices for RECs, et cetera. We have a procurement committee. We have adopted for the first time an environmentally preferred purchasing policy, which asks people to not only consider everything we consider: quality, reliability, availability, cost, regulatory compliance, but also environmental impact of what we buy and contract with. So that covers construction, all of our service contracts, and all of our purchasing. We also have the Environmental Justice Collaborative, which has been meeting for about a year now. And we are scanning the issues in the communities we serve that impact environmental health or environmental justice, risks to justice. And then we hope to be able to use our considerable community benefit investment. You might have noticed on that first slide, it was $1.5 billion. Actually, in 2020, it was $1.7 billion that we invest in communities. So we want to make sure that we're considering what we can be doing for climate resilience and avoidance of harm from either protection or education about the risks. And then the clinical collaborative, we'll be starting an affinity group this fall still, and then I hope to launch the collaborative this next year. We have had to slow that one down because of the pandemic. But clinicians, about 80% of the 120,000 caregivers are clinically focused, either licensed clinicians like physicians, nurses, pharmacists, respiratory therapists, or at least in the direct line of care delivery. So those are the experts. Those are the folks who know how to make these changes. They may not know they know this, but they do, because when we ask them questions about, well, how could we reduce the waste of this particular item? They're the ones who know. How could we actually move anesthesiologists to choosing safer chemicals? Well, they're the ones who know. So I'm really enthused about that work. I think that will basically, be amazing energy for this effort. This is the EJ Collaborative. I just told you about that. We also really work on caregiver engagement through communication largely. And the communication is, these are just some of the ways. I told you about ACEs. We have live events. Some of them are external. You can, if you're interested in this at all, you can Google for them. We have one, every few months that's externally facing on Facebook Live, YouTube Live, or LinkedIn Live. We have a SharePoint site that is loaded with all sorts of stuff that's not available externally. We have articles internally, and we participate in social media. Also quite a bit of national media as well. That's been one of our goals, and including related to COP26. We were the only health system in the United States invited to submit a case study, which we did. And our vice president was just last week on a presentation hosted by the British Embassy in Italy, because it's the COP26 is in Glasgow. The UK is the convener of the meeting. The UK has committed to decarbonizing healthcare. They're really the world leader. And so they were the ones who asked us to contribute as an American healthcare system. This is just a summary that has really come out of our planning process. Our vision statement is health for a better world. So you can see that there. And I've told you about We Act. So the statement on the left, we act together on health for a better world, applied to environmental stewardship, is we act to become carbon negative together with caregivers on health and justice by caring for our common home that we will pass to future generations. So this seems to have resonance throughout Providence. I know this is a lot of Providence speak here, but this has, as I said, made a difference to people, because surprisingly, actually, I felt like when we announced that goal during the pandemic that, well, we're not going to get any traction for a while, But what I found is that people were, even though they were overwhelmed by COVID and scared by COVID, especially before there were vaccines, they were also really relieved about this work. They were excited about this, because in our states, including Montana, we've lived through these heat waves and lived through the fires for the past 5 years or more, and people are freaked out. And so have found, and I'm grateful for it, that people have been really engaged with this work and excited to be part of it, and feel like there's hope. There are some solutions. So just finally, I showed you these two slides, and I really believe that this is up to us. It's up to us, those of us who are adults right now in human history. This is up to us. And so we're focusing on this resilient, healthy, regenerative, just world in what we're planning and what we're doing. And we feel like, not only as a role model for mitigation in our enormous commitment, but also the power of our voice as clinicians, yes, but also as one of the largest health systems in the nation with a global presence, that this is a way that we can impact this choice of which of these worlds are we going to be contributing to. So thank you. Those were my comments for now, and I'll turn back on my camera if I can figure that out, and would love to have a conversation.
Thank you so much, Dr. Schenk. Control-Shift-V is what we figured out at the beginning. I'm there. It's just really inspiring, and you don't know how timely. There's a lawnmower going behind my window, as there always is, because we're in the middle of, a lot of similar planning here at our institution. So I can see from the list of people that there's people who are really going to be interested in your talk. And so just open it up for questions. You can put your question in the chat. You can take yourself off mute and ask a question. You can raise your hand in the participant list. We have a small enough group. It should be not too crazy. Elise, did you have a question? No. While people get their thoughts together, I'll just ask one, which is, would you mind sharing any insights with respect to implementing this at Providence, about who have been the most important allies and any surprises or lessons learned about cultivating those allies within leadership of the institution?
Well, it's helpful for context. I think I've been working on this for a long time, at least 20 years, and have gone through I've been in Providence a long time and gone through series of leaders. And I'm always asking that question: how do we engage leadership? How do we get over the hump and make the difference between a leader saying, yeah, that's a problem, we should do something about it, to here's what I want you to do, here's what I want us to do. Yes, I support this. Yes, let's do this. Because of all the times when I talked to leaders and got that first response, yeah, no, you're right, we really need to do this, and then off to other things, there was a shift. I personally think that shift had to do with people living through the fires. That's probably simplistic, but I think there became a moment when it was both terrifying and so visceral. People could smell it. People could see it. People had to be evacuated. We had dozens of caregivers lose their homes in California. It's an enormous pressure. You think about that, and then you add the pandemic to it, and it's almost like, God, how do people tolerate it? In healthcare, because the pandemic has truly been a crushing challenge. It's unbelievable. You read about it in the paper, and it's really true. It has nearly broken a lot of people, and very, very hard. And yet, that's where we are. Not only in the pandemic, but in the climate crisis, and more people realize this. I tend to think that we're benefited from being in the states that we're in, including Montana, because we're in Missoula, where there's a lot of awareness. But in the rest of the West Coast states, I say this because I talk with people across the country. I talk with people in Florida and Alabama who are really struggling, people even on the East Coast who have the knowledge and the ability, but it's still hard to get the traction because of all the competing priorities. So I also think, basically, in Providence, we're a very mission-driven organization. Our mission revolves around service to the poor and vulnerable. We have core values that everybody, has memorized, and we truly, it's deep in our caregivers. And the one that this is associated with is justice. So it's justice for humanity, of course, but it's also justice for the rest of creation, and it's justice for future generations. And people are really motivated by their own concern. And then I think the framework that the mission and core values provide helps people get traction. It also, I believe, helps make it harder for people to run around it. That I think it's very powerful what that comment about our professional obligation. It's hard to deny that once you're aware of that. And then what do? People have to figure it out. So I think some of those reasons have helped. Now, we've been working for a long time, not just me, on making the business case. The business case, once you unpack it and understand it and have examples, is pretty easy. I often say you can't afford not to do this. And that seems to be getting more traction now, too, and people are actually being more creative about how to do that. Hope that helps a little bit.
Thank you for that. Who else would like to take advantage of this amazing expert we have for 10 more minutes? And if people sometimes take time to get their questions together. So I've got another one. I was pretty inspired. This is just really hitting close to home, but the environmental stewardship transformation circle that you mentioned, here at our institution, we're likely to end up in a space where we do have multiple, not necessarily hierarchical, but multiple missions that need to coordinate. And so I'm wondering actually how coordination among those different entities in the circle works. It must be extremely a fun opportunity given what a large organization you are. And are you the hub for all of that? And how do you manage that?
Yeah, great question. I think integration is really, really important. And we have worked hard on that. And it's a constant effort. It's not anything that you solve and then is solid, because we have constant turnover. We have about, right now, 30% turnover a year with COVID. So that's just like a steady stream of what's 30%? 40,000 people, 40,000 new people a year. It's like, well, but I knew from my years of working on this that it was very important to have different divisions together, because otherwise you're working in silos. People don't know where other people's pain points are. This has to be resolved together, and people need to learn about what others are up to and what their challenges are. They can help, and so luckily, I would say that another that's another benefit of Providence, because we are used to leading across divisions. A disadvantage is we are so geographically diverse. It's really hard to have the same effort in Alaska that you have in Lubbock, Texas. And so having that regional engagement is really pretty challenging, because you have to be both wide and deep at the same time. But I do think just by kind of, insisting is not the right word because it sounds negative, but by being consistent with the expectation that all divisions participate. And then, we have high level people in these divisions on the transformation circle. And I'm very grateful that they seem to all be engaged. They may not have the time. They've got a lot going on right now with the pandemic, but they'll pay attention. They watch the taped meetings. They contact us. We also give them assignments, basically. So it's not passive, so it's interactive. We want engagement, and we expect that. And it's a vice president who I report to, who reports to the president of the whole thing. So that helps to have high level support and leadership. Does that help some?
Yeah, thank you. Go ahead, Kathy.
Yeah, thanks. This is really inspiring. It's such great effort, and I'm really happy it's underway. So thank you for your talk. Several of us produced a climate assessment for Montana that looked at climate change and human health, and it had several recommendations in it. And I came to your talk a little late, so maybe you mentioned this, but I just wondered if that had been of any use in planning in Montana, that document, or if you'd had a chance to look at it.
Well, I'm one of the founding board members of Montana Health Professionals for a Healthy Climate with Rob and Lori Byron, who I'm sure you know well. And so yes, I would say it has informed that work more than Providence work. And I say that in part because of the 53 hospitals, 2 of them are in Montana, and it's in very far western Montana. So really, many of the impacts are related to wildfire smoke, trauma, heat, and mental health primarily. A little bit of vector illness. And so, yes, I think it has impacted that. And I think in terms of a conversation in Montana, it's, it's challenging, honestly, and also really important. As you know, we talk about that a lot with the Montana Health Professionals Group, and have worked on a variety of levels of outreach and education for a, minimally funded, non-staffed group of diehard clinicians, basically. And so I think that, we intersect with MSU in that regard, and we have a lot of, not a lot, but we have a number of faculty members who are part of that board. So I would say that is where the Montana Climate Assessment, also Nick Silverman's on the board, I'm sure you know Nick, has been important in our work. But, when we talk about our EJ work across the health system, I have 2 interns right now, very grateful, graduate student interns, who are doing scans in the communities that we serve. So one started in Alaska, seriously, the other started in Southern California, and we're learning about, well, what are the impacts, not just climate, but what about toxic exposures from industrial sites? What about exposures from, say, the Long Beach port in California? So those elements that really impact health in ways that I really think healthcare has been kind of blind to. I think the social determinants of health are important, but they're not sufficient. They don't capture a lot of that. They capture built environment. So that's a place we've really been trying to push our own understanding. And so that is a case when the health assessment is important, and we look for those in other states as well. Thank you.
Thanks.
I have a question. So how do you expect the type of initiatives, how do you expect to transition to a more sustainable healthcare system to look different in a, like, say, a rural hospital or a rural clinic than at like in a place like Portland or something like that. And then I think like how, I mean, what comes to my mind is it's just really hard for me to imagine healthcare as I know it, like without like single-use plastics or something like that. And kind of what does that intervention look like, and how, like, kind of what does the community development side of that look like, as well as like the technical side?
Yeah, thank you. Yeah, I often ask people when I start talking, just imagine the last time you were in healthcare. Think about it. What did you see in terms of environment? And the waste is what, just like, people are overwhelmed by it. And you think about that 29 pounds per patient day, like, wow. So two things I would say. First, about I think your example of disposable products. This is very frustrating in healthcare for people who are paying attention and working hard to reduce waste and reduce that source reduction, or the source. So I often say we want to differentiate between the value added use of these products and sheer waste, because we are here to provide safety and curing sometimes and healing all the time. And to do so, we need to use resources. I mean, if we looked at the world, I would say it's more important to use resources in healthcare than it is to use resources in, your 10th or 11th pair of shoes, or however many shoes is too many. I don't mean to guess at somebody's preferences, but it's a value added use of resources. But in healthcare, we still have just waste. People open two things. People drop something. We have things that come in packaging where you get, after you open layer after layer after layer, you get the thing, and you have this enormous pile of packaging. We have in our policies that we have to lay out different, materials to prep for X, Y, or Z. So some of that is necessary, but it's not all necessary. We have overly built in, perhaps this still, a lot of this needs to be studied in each particular case for the efficacy, the safety, because it's, a lot of that's about infection, convenience in terms of time and labor. That's an element. But I often say to people, we can start with the stuff that does not directly impact care. And then in time, I hope, through our habits of source reduction, which is really a lot of working with the vendors, and the development of new products, new plastics, different ways of being able to break down plastics and reuse plastics. So some of that's, I think, up to the industry and up to chemists, but still there's enormous room for improvement in what we do right now. It's really interesting when you start to ask people, hey, what could we do? They have ideas that just come out of the woodwork, and some of them are amazing. And so that's, I say that's where we start. I don't have an image yet of environmentally perfect healthcare, but I have lots of images of more perfect healthcare. And so that's that part of your question. The other part about rural communities, I think it's not terribly different in terms of the mitigation. We're working on basically the same things. It's like we act there as well. I think in a certain sense, our involvement in the communities is also similar, except it's a little bit more intimate. So for instance, in Montana, we have one very small hospital, critical access hospital in Polson, Montana, and it brings in just wonderful opportunities for interacting with the community, for working on the needs that they have there, for starting to look at some of the environmental issues, for working on more gardens and food security. And being, health hospitals are often anchors in the community, and we see ourselves as that. And so to do so in ways that help push us toward this other picture I showed you, the resilient, livable future that is just, I think that's probably not very specific for you, but I feel like it's very similar. It's just, it's just different settings. Also, I do think some of the work with our telehealth actually has been benefiting our rural communities, probably more so than our urban communities. That also has some environmental benefit. It also has some risk in terms of dehumanization and that sort of thing. So we'll see how that shakes out. But right now, that's just a part of life right now with the pandemic.
Well, with that, we'll wrap up and we'll let Dr. Schenk get on to what seems like a pretty impressive and amazing workload that you probably have for for you. Thank you so much for sharing that. It will be recorded. And so if you ever need to send people back to it, it's going to be a great resource for our broader audience going forward. So
Great.
thank you so much for the talk today. And thanks everyone for attending. We're very grateful. Paul Edlin says hello.
Hi, Paul.
And we'll see everyone next time. Thank you so much.
Thank you. Bye-bye.